Welcome to Pharmacology Insights, where we break down complex pharmacology into simple, easy-to-understand concepts. Diabetes pharmacology often feels confusing. Not because the drugs are difficult, but because we're usually taught them as isolated names on a list. Today, instead of memorizing drug classes, we're going to follow the disease through the body and watch how each drug steps in to fix a specific problem. Once you understand the story, the pharmacology stops feeling abstract and starts to make sense. To understand diabetes drugs, we first need to understand why blood glucose rises in the first place. In type 1 diabetes, the issue is simple but severe. The pancreatic beta cells are destroyed, so insulin is missing. Think of insulin as a key. Without the key, glucose can't enter the cells. The door stays locked, glucose piles up in the bloodstream. And the cells starve, despite sugar being everywhere. This is the empty tank problem. And the solution is straightforward. Replace insulin. Type 2 diabetes, however, tells a very different story. Here, insulin is present. Sometimes in large amounts. But the cells don't respond. The keys are there, but the locks are rusty. Muscle and liver cells resist insulin's signal. The pancreas compensates by producing more and more insulin until eventually it begins to fail. This is why type 2 diabetes isn't just an insulin problem. It's multiple organs breaking down at the same time, what we now call the ominous octet. So, let's map the battlefield. Glucose enters the body through the gut. It's regulated by hormones released after meals. The pancreas decides how much insulin and glucagon to release. The liver acts like a glucose factory, producing sugar even when the body doesn't need it. The muscles and fat tissue are supposed to absorb glucose. But in insulin resistance, they refuse. And finally, the kidneys, which normally reabsorb glucose, start holding on to far too much of it. Every anti-diabetic drug works by targeting one or more of these organs. We begin with the backbone of type 2 diabetes treatment, metformin. Metformin doesn't stimulate insulin. Instead, it goes straight to the liver and tells it to stop overproducing glucose. Since excessive hepatic glucose output drives fasting hyperglycemia, this single action makes metformin incredibly effective. And that's why it remains first-line therapy worldwide. Next are the drugs that fix the rusty locks directly. Thiazolidinediones, like pioglitazone, improve insulin sensitivity in muscle and fat by activating peroxisome proliferator activated receptor gamma, or PPAR-gamma, a nuclear transcription factor. The downstream effect is increased expression of the glucose transporters, especially GLP-4. The increased expression of GLP-4 increases the ability of cells to take up glucose when stimulated by insulin. In simple terms, the locks start responding to the key again. Glucose can finally enter the cell without forcing the pancreas to overwork. After meals, the gut doesn't just absorb glucose. It talks to the pancreas. This conversation happens through incretin hormones, especially GLP-1. GLP-1 receptor agonists, such as semaglutide, amplify this natural signal. They increase insulin secretion, but only when glucose is high. They reduce glucagon, slow gastric emptying, and increase satiety through central nervous system effects. This glucose-dependent action explains why GLP-1 agonists lower blood sugar with minimal hypoglycemia, while also promoting weight loss and providing cardiovascular protection. DPP-4 inhibitors take a subtler approach. Instead of adding GLP-1, they simply prevent its breakdown. DPP-4, or dipeptidyl peptidase 4, is a serine protease that normally degrades incretin hormones, GLP-1 and GIP. By inhibiting these enzymes, endogenous GLP-1 and GIP last longer, gently enhancing insulin release and suppressing glucagon, again, in a glucose-dependent manner. Some drugs bypass physiology altogether. Sulfonylureas and Meglitinides force insulin release by closing ATP-sensitive potassium channels on pancreatic beta cells. The cell depolarizes. Calcium enters. Insulin is released, regardless of glucose levels. A rise in plasma insulin increases glucose uptake and decreases hepatic glucose production. These drugs lower glucose effectively, but at a cost. Hypoglycemia, weight gain, and progressive beta cell exhaustion. They squeeze the pancreas, instead of supporting it. Finally, we reach one of the most elegant solutions in diabetes therapy. In the kidneys, sodium glucose cotransporter 2, or SGLT2 in the proximal tubule, reabsorbs about 90% of filtered glucose. SGLT2 inhibitors block this process, thus reducing glucose reabsorption and increasing urinary glucose excretion in the urine. No insulin stimulation. No beta cell stress. Just less glucose in the blood. The result: lower glucose, modest weight loss, and reduced blood pressure. And remarkable cardiovascular and renal protection. Sometimes, the best solution isn't using glucose better. It's getting rid of the excess entirely. Anti-diabetic drugs aren't random. Each one targets a specific organ, fixes a specific pathophysiological defect, and contributes to restoring metabolic balance. Once you think organ first, diabetes pharmacology stops being memorization and starts making sense. And that's it for today's pharmacology video. If you enjoyed this video, please give it a thumbs up and subscribe to the channel for more pharmacology content.